Perfect. I think this is time where we will continue. And I'm very pleased to introduce our next speaker, Dr. Mihail Petrov. And you're going to talk about your experience in stroke treatment after the golden hour. We're very excited to hear you talk.
Hello everybody, I'm an endovascular neurosurgeon at the University Hospital Pirogov. It's a pleasure for me to present our experience in endovascular treatment of stroke patients, especially a group of people that come a bit late in our center after the golden hour. Just a quick reminder about the trials that give us the golden hours. This is 4.5 hours for IVT and 6 hours for EVT. This is the trials that set this borderline and this threshold for these stroke patients with large vessel occlusions. After those 9 trials came up a few more trials that tried to prove efficacy of endovascular treatment of patients that come to the hospital after 6 hours of last known well. These two randomized control trials are the DAWN trial and the Diffuse 3 trial. Both trials used advanced imaging in order to enroll patients in those trials, and they divided the patients in 2 groups, thrombectomy versus no thrombectomy. Both trials proved great benefit for endovascular treatment. As you can see, the DAWN trial, the MRS 0 to 2 at 90 days is 49% versus 13%, and the Diffuse 3 trial also proves great benefit of the technique. So this is all about what's going in the world. I'm going to show our experience so far in the University Hospital Pirogov. So far we have treated 128 patients with large vessel occlusions and acute ischemic stroke. 1/3 of these patients, 31%, had an IVT before our treatment. The mean NIHS at admission is almost 17, so these are patients with a very severe stroke. The mean NIHS at discharge is 5. We had tandem occlusions around 15%. These are mainly patients with ICA and MCA occlusions or vertebral artery and basilar artery occlusions. The successful recanalization, this means TICI more than 2B, was achieved in 94%. On the pie chart, on the right you can see the various techniques that we have used so far. Mostly 57% we have used direct aspiration, a combined technique. We have combined all the Solumbra, the SAFE, various aspects of combined techniques in one group. This is 34%. Standalone, this is a very small group. These are patients with mainly dissections or acutely symptomatic carotid stenosis that went directly to stenting, and a very small group for intraarterial thrombolysis. These are less than 2%. These are patients with very distal occlusions with a low NIHS, but actually with a severe disability because of an eloquent area. For example, a patient without motor deficit but with aphasia were treated this way because of a very distal emboli. The MRS of our whole cohort at 90 days, 0 to 2 is 38%, 0 to 3 58%, the mortality is 25%. From all this patient pool, we have made a retrospective analysis, and actually 1/3, around 32% of our patients arrived quite late at the end of the therapeutic window at the brim of the threshold. When we looked inside this group of patients, some of these patients arrived around 4.5 hours, but when we started doing endovascular treatment in our hospital, the door-to-needle time started and the mean time was 2 hours and 19 minutes. So if a patient arrives at our hospital at 4.5 hours, when we start the procedure, we are already beyond the time limit and the golden hour. For example, if a patient arrives at 6 hours, even if we are very fast, we'll be starting the procedure after the golden hour. So the question was, is it worth it doing those patients? Do we have to exclude them? Do we have to deny them this kind of treatment? A small part of these patients were wake-up stroke patients, which actually had a last known well time beyond the golden hour, but actually, as most of the new studies show, these are actually not a late window, but an early window patients. That is why maybe you'll see there will be some shift of the results at the end of the presentation. So the great question is, should we exclude those patients? Should we actually do everything as they are we're doing a procedure that might take, for example, 1 or 2 hours? We'll show you 2 cases that are emblematic for the whole cohort of 32%. The first patient is a 70-year-old female patient, a neurologist actually, with an NIHS of 7 and left-sided hemiparesis. This patient, despite being a neurologist, came to our hospital 8 hours after last known well. The door to growing time in this patient was actually 1.5 hours. With the workup plan in our hospital of this patient is obtaining a plain CT, after that a CT angiography. Currently, we do not have the possibility to provide 24/7 CT perfusion or MRI perfusion, so we don't use it currently as a stratification whether to do or not to do a patient. Even that, when we had this patient with a very good plain CT and with noticeable absence of the right internal carotid artery and very good collaterals, we thought that we should do this patient. We had a talk with her relatives that were all doctors. Even she had a relative, he's an invasive neurologist in the US. So we had the green light to do the procedure. What we saw was a complete occlusion of the right ICA. We did 1 aspiration, perfect recanalization, TK3. The patient was discharged on 5th day, NIHS 2, 90 days MRS 1. The second patient is a 41-year-old immigrant patient from Syria, so we had a little bit of problem with language barrier and so on. Finding relatives, he arrived with an NHS of 13, left-sided hemiparesis. You can see on the left a very good aspect score on the native CT. Unfortunately, this patient arrived more than 10 hours from last known well. While we were working up this patient, almost 2.5 hours also elapsed. So there was a great question whether we should treat this patient or not. You can see on the CT angio, we have occlusion of the right ICA again. So we decided to go in the angio suite. The thing that you see on the clip actually is the stagnation of the contrast in the right ICA. This could, the conical shape of the contrast could either, the differential diagnosis in such a young patient might be a dissection, but actually might be also a distal embolus, for example, a T occlusion, and the stagnating contrast at the back wall of the ICA also can signify that. We entered in the ICA with an aspiration catheter. We saw the occlusion, one-time aspiration. You can see in the siphon there was a stenosis, but the patient actually improved on the table, and we decided not to do anything about the stenosis. We loaded the patient with a double antiplatelet therapy, and you can see the result. He was discharged on 9th day, NHS 0, 90 days MRS 0. So we divided the results of the whole cohort of 130 patients and the small cohort, 30% of patients that were done after the golden hour. As you can see, the results are almost identical. The NHS almost identical, the recanalization rate almost identical, the MRS at 90 days almost identical. The mortality rate is actually a bit striking, but actually there is explanation for this. Although these patients are late window or beyond the threshold, they actually have good collaterals. Good collaterals lead to better outcome, no matter what time these patients have been worked. So the take-home messages: these patients should be treated. Advanced imaging, it should be done also if you have this possibility. Time is important, but actually collaterals are more important. Good initial imaging gives you a very good perspective of this patient and actually restarts the clock. This means that even if the time is 10 hours, 12 hours, the good initial imaging means that you have good collaterals and the patient is worth the procedure. Wake-up stroke patients, actually should not be included in this group because they are actually not late window patients. They are early window patients because actually most of these patients don't do their stroke when they go to sleep. They do their stroke when they wake up, or for instance, 1 hour before they wake up. There are two very important things when treating stroke patients. One of these things is the good team. You can see we have a very good interdisciplinary team, cardiologists, neurologists, neurosurgeons, and the other very important thing about treating stroke patients is focusing on the patient. You can see if you do everything possible. This is our first patient a few years back that we did MCA occlusion through a radial approach because she didn't have femoral access. So get good and good results will come. Thank you for your attention.
Thank you very much for this really important presentation, and you're totally right. It's the collaterals.
Yeah.
It's not the time.
Yeah.
It's the physiological time window of the brain that counts. We should be forgetting about the time concept, and we should be looking at the patient individually. I think that's what you.
Yeah, absolutely. I mean, and we know it from the latest randomized trials that basically you don't even need advanced imaging to identify your patients. I mean, in the Mr. Clean Late, what they did is they randomized the patients who would not qualify based on advanced imaging. And what they found out is they are profiting from thrombectomy. Of course, if you're doing these broad indications, you will end up with a mortality rate that will be higher than these very impressive ones that you presented. But in the same time, if you look in the big picture, you're helping more and more patients.
About the mortality, there is a very simple explanation. In Bulgaria, we don't have very good connection between hospitals and rehabilitation centers. That's why we don't discharge MRS5 and send them to rehabilitation centers. These patients are left in hospital, for example, for 3 or 4 months. So actually the mortality rate is because most of the patients from, for example, MRS5 actually go to MRS6, and that's why we have high mortality and very low number of patients with MRS5. This is actually the explanation of the mortality rate.
Thank you very much. Thank you.